In this video, we are going to discuss about cyanotic congenital heart disease. Cyanotic congenital heart disease is divided into two types. There are certain diseases in which there is decreased pulmonary blood flow, and there are certain diseases in which there is increased pulmonary blood flow. So there are three conditions in which there are decreased pulmonary blood flow. One is tetralogy of Fallot, tricuspid atresia, Epstein anomaly. In case of tetralogy of Fallot, decreased pulmonary blood flow is due to RVOT obstruction or infundibular hypertrophy that leads to decreased pulmonary blood flow. In case of tricuspid atresia, there is atretic tricuspid valve, so no blood from right atrium goes to right ventricle. The blood from the right atrium goes to left atrium via the atrial septal defect, and from the left atrial it goes to the left ventricle, and from the left ventricle via ventricular septal defects it reaches the right ventricle. So the amount of blood reaching the right ventricle is very less, so that's why there is decreased pulmonary blood flow in case of tricuspid atresia. In case of Epstein anomaly, there is atrialization of right ventricle. That means the right ventricle size is reduced, so its capacity is decreased, so there will be decreased pulmonary blood flow. So there are three conditions, three cyanotic congenital heart disease with decreased pulmonary blood flow. They are tetralogy of Fallot, tricuspid atresia, and Epstein anomaly. There are certain diseases in which there is increased pulmonary blood flow. They are HLHS, hypoplastic left heart syndrome, truncosarteriosus, transposition of great arteries like TGA, total anomalous pulmonary venous connection. You can remember it, the conditions, these conditions in which there is increased pulmonary blood flow in cyanotic congenital heart disease. HTT. A stands for HLHS, hypoplastic left heart syndrome. T stands for truncosarteriosus. Another T stands for transposition of great arteries, TGA. Another stands for TAPVC. So patients with atrial ventricular septal defect have increased pulmonary blood flow. In case of patients with atrial and ventricular septal defect, they have increased pulmonary blood flow. This results in recurrent pulmonary infection due to congestion in lung. When there is increased pulmonary blood flow, there will be obviously congestion in the lung. It predisposes them to develop infection. Tetralogy of Fallot and tricuspid atresia are associated with reduced pulmonary blood flow. Oligemic lung fields. They do not cause pulmonary congestion and do not cause or do not predispose to infections. Reduced pulmonary blood flow is due to right ventricular outflow tract obstruction in tetralogy of Fallot, right ventricular inflow obstruction in case of tricuspid atresia. Okay, so again this table comes diseases with decreased pulmonary blood flow: tetralogy of Fallot, Epstein anomaly, tricuspid atresia with intact ventricular septum, and pulmonary atresia. In pulmonary atresia or pulmonary atresia, there will also be decreased pulmonary blood flow. Transposition of great vessels with VST and pulmonary stenosis. Transposition of great vessels means the position of great vessels are changed. Now instead of joining the left ventricle, aorta joins the right ventricle and pulmonary artery joins the left ventricle, and there is pulmonary stenosis. This is a condition, there is decreased pulmonary blood flow. In case of increased pulmonary blood flow seen in transposition of great vessels, VST or PDA. VST, AST, PDA, in all these conditions there is increased pulmonary blood flow that predispose them to develop infections in the lung due to prolonged congestion. Another is TAPVC, truncosarteriosus, hypoplastic left heart syndrome. So in this condition there is increased pulmonary blood flow. So what is the difference between pulmonary plethora and oligemia? Let's discuss that. Pulmonary plethora means there is increased pulmonary blood flow, increased vascular markings on the chest X-ray due to increased blood flow to the lungs. Why it happens? It happens because of left to right shunt. Left to right shunt we discussed in AST, VST, PDA. In all these conditions there is increased pulmonary blood flow that leads to pulmonary plethora. Example AST, VST, PDA, and another AST, VST, PDA are acyanotic congenital heart disease. There is a cyanotic congenital heart disease in which we see pulmonary plethora, that is TGA, transposition of great arteries. Transposition of great artery, why it causes that? So in case of TGA, there is change in position of both great arteries. That means instead of coming from the left ventricle, the aorta comes from or joins the right ventricle, and the pulmonary artery joins the left ventricle. Left ventricle has more pressure inside that, and so when left ventricle pumps through the pulmonary artery, that leads to increased pulmonary blood flow to the lungs because of left ventricle. Instead of connecting to right ventricle, when pulmonary artery is connected to left ventricle, due to high pressure in the left ventricle, more blood is pushed into the lungs via the pulmonary artery. That leads to pulmonary plethora. So TGA is a cyanotic congenital heart disease in which you see pulmonary plethora. Most specific cardiac defect in gestational diabetes. So in gestational diabetes mother, the child can develop cardiac defect. Most commonly develop VSD, and most specific cardiac defect in case of infant of diabetic mother is TGA, transposition of great arteries. Sequence: left heart high pressure, blood crosses the right heart, more blood enter the pulmonary artery, lung receive excess blood, vessels enlarge, and there is pulmonary plethora. On chest X-ray, there is prominent hilar vessels and increased vascular markings extending to lung periphery. Lungs look whiter because vessels are visible. This X-ray film looks more whiter. Clinical use: pulmonary overcirculation can eventually lead to pulmonary hypertension. When there is increased pulmonary blood flow for a long time, there will be protective mechanism in the lung that will develop, that will lead to vasoconstriction of the pulmonary artery and arterioles. Further, that will lead to the hypertrophy of the muscles, smooth muscles which are present in the tunica media. That will lead to permanent changes, and there will be increase in pressure inside those vessels that will lead to pulmonary hypertension. When once pulmonary hypertension develop, it is called Eisenmenger syndrome. Now there will be reversal of sound. This left to right sound will be reversed to right to left sound. Okay. In case of pulmonary oligemia, there is decreased pulmonary blood flow. Definition is decreased vascular markings because of less blood reaches the lungs. Why does it happen? It happens due to right ventricular outflow tract obstruction. Right ventricular outflow tract obstruction is seen in case of tetralogy of Fallot. And right to left sound. Right to left sound. In case of Eisenmenger syndrome, we see right to left sound. Example is tetralogy of Fallot. There is decreased pulmonary blood flow due to this region. Pulmonary atresia, there will be decreased pulmonary blood flow. Severe pulmonary stenosis, also there will be decrease in blood flow. And tricuspid atresia with pulmonary stenosis. It is also cause of oligemia. Sequences: here is pulmonary stenosis, less blood enters the pulmonary artery, less blood reaches the lung, and pulmonary vessels become small. Pulmonary oligemia. On chest X-ray, sparse vascular marking, darker or hyperlucent lung field because there are few visible blood vessels because of decreased pulmonary blood flow. So neonate with cyanosis, or a newborn with cyanosis and plethora. Newborn present with cyanosis and plethora. What do you think? You think of transposition of great arteries, because TGA is the only cyanotic condition in which you see plethora. Okay, so pulmonary artery arising from left ventricle, increased blood flow to the lungs. Another finding in case of TGA is egg on string appearance due to narrow positioning of great vessels. There will be string, and egg is due to heart. And child with cyanosis and oligemia. Here newborn or neonate with cyanosis and plethora due to TGA. Child with cyanosis and oligemia in chest X-ray is due to tetralogy of Fallot. In that condition, we see boot-shaped heart. Now let's discuss one by one. Tetralogy of Fallot, 4 components. One is subpulmonary stenosis, right ventricular outflow tract obstruction, and infundibular hypertrophy. So this is that: obstruction of right ventricular outflow tract and subpulmonary stenosis. Then we have RVH, right ventricular hypertrophy. Once this passage is narrow, now right ventricle has to pump more to push blood through that, so that will lead to hypertrophy of the right ventricle. So first is this right ventricular outflow tract obstruction, then right ventricular hypertrophy, then ventricular septal defect. There is a ventricular septal defect present here between them, but in this case there will be no pansystolic murmur. And overriding of aorta. Now this aorta overrides the pulmonary artery. So all these are the 4 findings in case of tetralogy of Fallot. Remember one thing: decreased pulmonary blood flow. Pulmonary blood flow is inversely proportional to infundibular hypertrophy or subpulmonary stenosis. as the infundibular hypertrophy increases or pulmonary stenosis increase, there will be decreased pulmonary blood flow. So in condition we have pentalogy of Fallot, just add AST. Instead of trilogy of Fallot, just eliminate VST. So this is pentalogy and trilogy of Fallot. Cyanosis at onset within 4 months after birth varies with subpulmonary stenosis. So within 4 months of birth, the baby will present with cyanosis in case of tetralogy of Fallot. And there are other some cyanotic congenital heart disease. The newborn will itself present with cyanosis, as in case of TGA. So single S2, A2, P2. P2 is not hot due to pulmonary stenosis. So A2 is only hot. That's why it's called single S2. Ejection systolic murmur when the blood crosses through the pulmonary, ejected from the right ventricle to the pulmonary artery. There will be an ejection systolic murmur in pulmonary area, disappear during cyanotic spell. So this is the most important point. You will always hear a ejection systolic murmur in the pulmonary area, but this ejection systolic murmur, it disappears during cyanotic spell. Then it is the surest sign of tetralogy of Fallot. If the murmur disappears during cyanotic spell, ejection systolic murmur, then it is the surest sign of tetralogy of Fallot. Cyanotic spell. So what is cyanotic spell? Cyanotic spells means increased severity of cyanosis. The cyanosis becomes more intense. So this is also known as TET spell. So how this develops? So if the baby is crying, doing much exercise, feeding pain, crying, exercise, feeding pain, these are the triggers that lead to catecholamine surge in our body. Crying, exercise, feeding pain, that lead to catecholamine surge. When the catecholamine level increase, that lead to infundibular spasm, or it worsens the right ventricular outflow tract obstruction. So there will be decreased blood flow to lungs. When there is decreased blood flow to lungs, there will be development of hypoxia. Hypoxia can lead to seizure or syncope, and it can lead to metabolic acidosis. So decrease in systemic vascular resistance. When the systemic vascular resistance decreases, the afterload of the left ventricle decreases. That leads to decrease in left ventricular pressure. In case of tetralogy of Fallot, there is a connection between left and right ventricle. When the left ventricular pressure decreases, the deoxygenated blood from the right ventricle comes towards the left ventricle. So sudden spasm of right ventricular outflow tract or infundibular spasm lead to what this will lead to? This will lead to when there is infundibular spasm, now the blood in the right ventricle can't go towards the pulmonary artery, so it accumulates in the right ventricle and the right ventricular pressure increases. Now there is a VST present in between right ventricle and left ventricle. Due to decrease in systemic vascular resistance, the LV pressure falls. Now we are in a condition in which right ventricular pressure is more than left ventricular pressure, and a ventricular septal defect is present in between them. So there will be shunt reversal, right to left shunt. More deoxygenated blood from the right side will come to left side and get mixed with the oxygenated blood, and it will go to our body. So pulmonary stenosis, that will lead to right to left shunt via VSD, decreased blood flow to lungs, and severe hypoxia cyanosis. More deoxygenated blood crosses the VSD from the right side to the left side instead of going to the lungs. That will lead to decreased pulmonary blood flow. So it will lead to severe cyanosis. So how will you manage it, or how it is managed normally? So if a children is doing squatting in children or knee chest position in infant, that lead to femoral artery compression. Squatting in children or knee chest position in case of infant, that lead to femoral artery compression. When the femoral artery gets compressed, there will be increase in systemic vascular resistance. When the systemic vascular resistance increases, afterload for the heart increases. So when the afterload for the heart increases, there will be a rise in LV pressure. Now less blood from right ventricle will come to left ventricle, because now the LV pressure is also increased. So that will relieve some condition of cyanosis, because when from the right side to the left side, when blood was coming, they are all deoxygenated blood. So squatting and phenylephrine also a vasoconstrictor, that will also lead to rise in systemic vascular resistance. So rise in systemic vascular resistance, phenylephrine and squatting is due to femoral artery compression, and rise in systemic vascular resistance leads to decrease in right to left shunt. When the systemic vascular resistance rises, now there will be decrease in right to left shunt, because on the left ventricle, now pressure is also increased. Right to left sound occurs the VST, and it pushes more blood towards the lungs. That will lead to pushes more blood, then there will be improvement in cyanosis. So there will be improvement in cyanosis. What are the management of this condition, that is cyanotic spell or dead spell? We give 100% O2 and morphine. Morphine is due to used to reduce crying and hyperapnea. Propranolol, it is used for infundibulous spasm, it is a beta blocker. And phenylephrine, that increases systemic vascular resistance. When systemic vascular resistance is increased, there will be less right to left shunt, more blood will enter towards the lung, and there will be improvement in case of cyanosis. And IV fluid can be given to increase afterload, as phenylephrine or squatting increases the systemic vascular resistance and increases the afterload. IV fluid can increase the preload. So for correction of acidosis, we give soda bicarb, NaOCO3. So treatment of hypercyanotic spell involves the knee chest position or squatting, use of oxygen, morphine sedates the patient, sodium bicarbonate to counteract metabolic acidosis that developed when arterial PO2 less than 40 mm of Hg. Alpha agonists like phenylephrine, vasopressor used in some cases. Beta blockers like propranolol improves the resting saturation and decrease the frequency of spells. Drugs that increase systemic vascular resistance include phenylephrine, alpha-1 agonist, propranolol non-selective beta antagonist, beta-2 blocker, and can improve right ventricular outflow and decrease right to left sound. To improve symptoms, the same principle is squatting. Now we discuss about the tetralogy of Fallot. Now let's move on to tricuspid atresia. Tricuspid atresia, there is atretic tricuspid valve that lead to decreased blood flow to right ventricle. Now it is a cyanotic congenital heart disease, and there is decreased pulmonary blood flow. So tricuspid atresia is often associated with AST, PFO or VST. So now what takes place? Now deoxygenated blood comes from the superior vena cava towards the right atrium, and from the right atrium, as the tricuspid valve is atretic, it will go to left atrium via the present atrial septal defect. Now from the left atrium, this blood goes towards the left ventricle, and there is a VST also present. From the left ventricle it goes to right ventricle, and right ventricle goes to pulmonary artery. So this is what happens in case of tricuspid atresia. So after load to left atrium and left ventricle is increased, that will lead to hypertrophy of the left heart, and hypertrophy of left heart lead to left axis deviation. So what is left axis deviation? Left axis deviation is minus 30 to minus 90 degree. It is seen in QRS where lead 1 is positive, lead FF is negative, and lead 2 is negative, So this is the common part. So there will be left axis deviation in this case. Now let's discuss about Epstein's anomaly. Epstein's anomaly is due to arterialization of the right ventricle, inferior or apical displacement of the septal leaflet of tricuspid valve, decreased size of right ventricle, and decreased right ventricular volume, decreased pulmonary blood flow. So Epstein's anomaly is due to lithium exposure to the mother accessory pathways on the right side of heart, like WPW syndrome. That is called bundle of Kent. Bundle of Kent is the abnormal connection between right atrium and right ventricle. Pre-excitation of right ventricle leads to slurring of QRS complex. So this is the ECG finding in case of WPW syndrome or Parkinson-White syndrome. So in that condition we see short PR interval less than 120 millisecond or less than 0.12 second, less than 3 small square a day. Short PR interval wide QRS complex. Short PR interval wide QRS complex more than 3 small squares or more than 120, and 1 small square is equal to 40 millisecond or 0.04 second. So 3 small square is equal to 120 and millisecond and 0.12 second. HLSS is hypoplastic left heart syndrome, atresia of mitral valve, no connection between left atrium and left ventricle. In case of HLS, there will be atresia of mitral valve that will lead to no connection between LA and LV, hypoplastic LV. So the LV is hypoplastic, and hypoplastic aorta. There will be decreased systemic severity of systemic flow that will lead to shock in neonates. So in case of HLSS, it will present as shock in neonates. So there is atresia of mitral valve. So there will be no connection between left atrium and left ventricle. There will be hypoplastic left ventricle, underdeveloped left ventricle, and hypoplastic aorta. That will lead to very severe decrease in systemic flow, and it will lead to shock in case of neonates, and it is fatal if untreated. And now we'll discuss about truncosatirius. Truncosatirius, there is a common trunk for both left ventricular outflow tract and right ventricular outflow tract. Common outflow tract for both oxygenated and deoxygenated blood. It is associated with VST and present with cyanosis. A truncosatirius is a cyanotic congenital heart disease, a type of conotruncal defect. So this truncosatirius is a type of conotruncal defect. In tetralogy of Fallot, interrupted aortic arch. All these are example of conotruncal defects. So conotruncal defect example are TGA, TOF, interrupted aortic arch. It is this conotruncal abnormalities are associated with DiGeorge syndrome. DiGeorge syndrome is 22q11.2 macrodeletion, and there is mnemonic is CATCH22. So A stands for hypoglycemia. Here is hypoglycemia due to decreased PTH, and it is due to mostly third and fourth pharyngeal pouch underdevelopment, and from the third pharyngeal pouch, inferior parathyroid gland and thymus develop. So in absence of third pouch, there will be thymic hypoplasia and hypoparathyroidism. In the fourth pouch, there is superior parathyroid glands, so that is also deficient, so there will be no PTH. Now let's discuss some conditions like CHARS syndrome. CHARS, C stands for coloboma, A stands for heart disease, A stands for atresia, or it is called choanal atresia, G are CHARS, coloboma, heart disease, choanal atresia, and it is retardation. Retardation means growth retardation and ear abnormalities. So this is what is choanal atresia. In normal anatomy, this is the nasal passage. This is the nasal passage. In case of choanal atresia, bony or membranous obstruction of the nasal pathway. Bony or membranous obstruction of nasal pathway is known as choanal atresia. Now let's discuss some other genetic conditions. In Marfan syndrome, aortic root dilatation, aortic dissection can develop, and that is fibrillin 1 mutation, autosomal dominant in chromosome 15q. Mitral valve prolapse can be there, and superotemporal lens subluxation. Superotemporal lens subluxation is a characteristic of this Marfan syndrome. And in homocystinuria, there will be also tall stature like Marfan syndrome, but there is lens dislocation inferonasal. So superotemporal lens subluxation is seen in case of Marfan syndrome. Inferonasal is seen in case of homocystinuria. In case of Alagille syndrome, we see pulmonary stenosis, triangular fascic cholestasis. Alagille syndrome is pulmonary stenosis, triangular fascic cholestasis. In case of Holt-Oram syndrome is autosomal dominant. So most common cardiac disease seen in case of Holt-Oram syndrome is ASD. It is ASD. ASD is the most common congenital heart disease in case of Holt-Oram syndrome. So there will be absent radius and thumb. Absent radius and thumb plus ASD, you think of Holt-Oram syndrome. Williams syndrome, supravalvular aortic stenosis. Williams syndrome is supravalvular aortic stenosis. There will be increased calcium, hypercalcemia, and Elfin phasis. In case of congenital rubella syndrome, PDA greater than equal to PS greater than equal to VST. SLE, heart block due to anti-RO, anti-SSA, anti-LA, anti-SSB antibody. GDM, infant of diabetic mother of motherhood gestational diabetes. Most common defect is VST, ventricular septal defect. Most specific is TGA. Most specific in case of diabetic female who gets pregnant, it's how his or her child is going to develop TGA. Because it is more specific. Noonan syndrome, there will be pulmonary stenosis and AST. Turner's syndrome, there will be coarctation of aorta, bicuspid aortic valve. Turner syndrome means there will be coarctation of aorta and bicuspid aortic valve, increase the risk of aortic stenosis, as bicuspid valve increase the risk of stenosis and tricuspid valve increase the risk of regurgitation. Now let's go to transposition of great arteries. So transposition of great arteries, we have discussed transposition with intact ventricular septum. If the ventricular septum this is intact, there will be parallel circulation. As in here blood from the superior vena cava, inferior vena cava comes to right atrium. From the right ventricle via the tricuspid valve goes to right ventricle. From the right ventricle it goes to aorta, and from the aorta, from the body, it again comes to the vena cava and from the right side. So this deoxygenated blood, it keeps on moving like this in case of right side. In case of left side, blood is healthy blood or oxygenated blood is coming from the lungs via the pulmonary veins, and there is now then again this is going through this pulmonary arteries which is connected to the left ventricle. Now from the pulmonary arteries this goes to this oxygenated blood again goes to lungs, and this is another parallel cycle which continue here. So it is a parallel circulation. In case of transfusion of great arteries, to separate blood from tract for oxygenated and deoxygenated blood. Early onset cyanosis can be fatal within few minutes. So early onset cyanosis in case of transposition of great arteries is fatal. Treatment of TGA with intact ventricular septum. If the ventricular septum is intact, then how to treat this case? It is an emergency condition. We give prostaglandin E1 infusion immediately at birth. So we give prostaglandin E1 infusion immediately at birth, which keeps the ductus arteriosus open. Ductus arteriosus open means oxygenated blood from the pulmonary artery to aorta. Oxygenated blood from the pulmonary artery to aorta. And another treatment we have that is called arterial septostomy. Arterial septostomy, surgical correction between LA and RA, and there we make a hole between LA and RA that will lead to mixing of blood. Here it is one side there is only deoxygenated blood, and another side there is only oxygenated blood. You have to keep them undergo mixing in order to improve the our prognosis. So definitive treatment management is Jatten's arterial switch repair. So Jatten's arterial switch repair is the treatment of choice or the final definitive treatment in case of transposition of great arteries. Okay. Now let's discuss another condition, that is TGA with intact with ventricular septal defect. In this condition there is only TGA, no VSD. If the TGA is with VSD, then present with less intense cyanosis, and blood from the left ventricle goes to right ventricle, there will be mixing of oxygenated blood and deoxygenated blood, and that will lead to cyanosis. So that is the management. General management is Jatten's arterial switch repair electively few weeks after birth. Now let's discuss about TAPVC, total anomalous pulmonary venous connection, abnormal connection between pulmonary vein and right atrium. Normally from the lungs oxygenated blood via the four pulmonary veins to left atrium, then it goes to left ventricle, then it goes to all over the body. And in case of TAPVC, pulmonary vein drains into an abnormal vein instead of draining into left atrium. Now the pulmonary vein drains into an abnormal vein, and that abnormal vein drains into right atrium. So there is connection between pulmonary vein and right atrium. In lungs, oxygenated blood, pulmonary veins. In lungs, oxygenated blood from the lungs comes, it carries on via the pulmonary veins, and again this blood goes to abnormal vein, and this abnormal vein transfers this blood into right atrium. If there is any narrowing or obstruction in abnormal pathway, if there is, we can divide it into two types: obstructive type TAPVC or non-obstructive TAPVC. If there is any narrowing or obstruction in the abnormal pathway, if this in this abnormal pathway there is any narrowing or obstruction, then it is called obstructive type. If there is no obstruction in case of while blood flowing through this abnormal vein, then there is non-obstructive type. In obstructive type, pulmonary venous congestion of the lung. If this vein is congested, then there will be increased back pressure, and that will lead to pulmonary venous congestion. Congestion of lung can lead to severe cyanosis. Infracardiac TAPVC is the most commonly associated with the obstruction. Infracardiac TAPVC, when the pulmonary veins join the hepatic veins or portal vein or inferior vena cava, it travels the abnormal vein, it goes through a long course, so it is more at risk of undergoing obstruction. So infracardiac TAPVC is the most commonly associated with obstruction. If there is no obstruction, then it is called non-obstructive type. Non-obstructive type most common equal to oxygen saturation in all heart chambers. Most common is non-obstructive. It is more common than the obstructive type. Equal oxygen saturation in all the 4 chambers in case of non-obstructive type of TAPVC. So now this is a supracardiac TAPVC. This abnormal vein or pulmonary vein joins with superior vena cava and superior vena cava. This both oxygenated blood and deoxygenated blood in blue, they come here, and via the AST they go to left atrium, via the mitral valve they go to left ventricle, and here they go to also right ventricle. So there is equal oxygen saturation in all heart chambers. So equal oxygen saturation in all heart chamber is non-obstructive type of TAPVC. So the other types, supracardiac, pulmonary vein drain into superior vena cava or innominate vein. Cardiac, right atrium directly drains into coronary sinus. In case of cardiac type of TAPVC, right atrium directly drains into coronary sinus. Infracardiac, IVC, hepatic vein. So this is the snowman or figure of 8 appearance. It is seen in supracardiac TAPVC, snowman appearance or figure of 8 appearance in case of chest X-ray due to increase in SVC size. So this is supracardiac TAPVC. This is the pulmonary vein. It is joining with the superior vena cava. It is known as supracardiac TAPVC. Joins with superior vena cava, innominate vein. Cardiac TAPVC means the pulmonary vein joins through the coronary sinus and it drains into the left atrium. Instead of draining towards the left atrium, now this pulmonary vein drains into right atrium through coronary sinus. Infracardiac TAPVC means it is due to IVC, hepatic vein or portal vein. These are the abnormal vein. Now this pulmonary vein drains into IVC, hepatic vein or portal vein, then it drains it into right atrium. So there is indirectly connection between right atrium and pulmonary vein. Most common associated obstruction due to long course. The right upper limb is the best area to check pre-ductal oxygen saturation. So right upper limb is the best area to check the pre-ductal oxygen saturation in a newborn infant, as it receives blood primarily from the right brachial artery. So right upper limb is the best area to check the pre-ductal oxygen, because from the aorta there will arise left common carotal artery, left subclavian artery, all these things. After that there will be ductus arteriosus, and from the ductus arteriosus blood comes and mixed with aorta. So that is not a good idea to check for oxygen saturation. So right upper limb is the best area to check pre-ductal oxygen saturation in a newborn infant, as it receives blood primarily from the right brachial artery, which arises from aorta before ductus arteriosus. So this right brachial artery, it arises from the aorta before ductus arteriosus. In the routine neonatal screening for congenital heart disease, saturation probes are placed on the right upper limb, pre-ductal, and right lower limb for post-ductal. So right upper limb oxygen saturation is measured as pre-ductal oxygen saturation, and right lower limb it is measured as post-ductal respectively. Now let's come to treatment. Definite treatment in case of tetralogy of Fallot is VSD repair, correction of stenosis, VSD repair, ventricular defect repair, and correction of infundibular stenosis or infundibular hypertrophy. It is preferred in less than 3 months of age. It is a palliative surgery or sound surgery to improve the pulmonary blood flow. Palliative surgery purpose is not to treat fully, it is to increase the pulmonary blood flow that will improve cyanosis. Palliative or sound surgery in delayed presentations, no, there will be, if there is some contradiction to definitive surgery, then we do the palliative surgery. It is a shunting of systemic artery to pulmonary artery. The main issue here is decreased pulmonary blood flow. What we do is that we will increase pulmonary blood flow by increasing another systemic artery into the pulmonary arteries. So it is done as Belloc-Taussig shunt. So classic Belloc-Taussig shunt means this right-sided subclavian artery is connected with pulmonary artery. When the right-sided subclavian artery is connected with pulmonary artery, we call it classic Belloc-Taussig shunt. In case of modified Belloc-Taussig shunt, there is an artificial conduct used to connect right-side subclavian artery with the pulmonary artery. And another two sound we have, one is called waterstone sound, another pot sound. In waterstone sound, then the pulmonary artery is connected with ascending aorta. In waterstone sound, the pulmonary artery is connected with ascending aorta. In case of pot sound, the pulmonary artery is connected with descending aorta. In case of tricuspid atresia, multiple sound surgery performed in stages. There will be performed multiple sound surgery will be performed in phases. Modified Wheeler toxic sound done immediately. Modified Wheeler toxic sound, what it does is that by artificial conduct it joins pulmonary artery with right brachiocephalic trunk or right subclavian artery, followed by Glenn stunt. Glenn stunt is superior vena cava connected to pulmonary artery. In case of tricuspid atresia, we decrease the blood is coming to right atrium, then it is shunting to left atrium. There will be volume overload in left atrium and left ventricle, that will leading to left extubation. So our purpose is to decrease the left atrial hypertrophy. We can do that by decreasing the blood flow to the left atrium. We can do that by decreasing the blood flow to right atrium, because there is defect between left atrium and right atrium. If you decrease blood flow to right atrium, there will be obviously decreased left atrial flow. So how we can do that? We can do that by directly diverting the blood from the vena cava towards the pulmonary artery. So it is called Glenn sound. In Glenn sound, superior vena cava is connected to pulmonary artery, followed by Fontan sound. So first Glenn sound, then GF, Fontan sound. Fontan sound is inferior vena cava is connected to pulmonary artery. So if inferior vena cava is connected to pulmonary, there will be no blood going to right atrium, no blood going to left atrium, there will be decrease in pulmonary hypertrophy. So first we do the modified Wheeler tossing sound, then we do the Glenn sound, then we do the Fontan sound. Glenn is superior vena cava connected to the pulmonary artery, Fontan is inferior vena cava connected to pulmonary artery. In case of Epstein's anomaly, we do the cone repair of tricuspid valve. So Epstein's anomaly, we do the cone repair of tricuspid valve and return valve to its original position. In case of hypoplastic left heart syndrome, we do Norwood procedure. So what is Norwood procedure? That is the procedure done in case of hypoplastic left heart syndrome. Surgical correction of newborn with increased blood flow. Surgical correction with creation of new aorta with increased blood flow. In HLSS is the normal heart hypoplastic left heart syndrome. In case of hypoplastic left heart syndrome, the normal heart. In case of hypoplastic left heart syndrome, the left heart is hypoplastic. So what we can do is we can do Norwood procedure. So this is what another new aorta is created, Cyanotic. So this is Norwood procedure. In case of truncosarteriosus is partition, there will be normal blood flow. It is called Rastellis procedure. In case of now you can see this pulmonary artery is connected to the right ventricle and the aorta is connected to the left ventricle. It is known as Rastellis procedure, separation of this truncosarteriosus. In case of TGA, transposition of gate, we discussed earlier, Japanese arterial switch repair. So this is Japanese arterial switch repair. Here the pulmonary artery is connected to the left ventricle. Now we connect the pulmonary artery into the right ventricle, and the aorta which is connected in the right ventricle, we connect that into left ventricle. So this is Japanese arterial switch repair. This is Rastellis procedure. This is Norwood procedure in case of HLSS. So these are the treatment options available in our case of congenital cyanotic heart diseases. Now discuss some questions. A newborn has severe cyanosis immediately after birth. Severe cyanosis immediately after birth means you think of TGA. Echocardiogram shows TGA and intact ventricular septum. Now this ventricular septum is intact, there is no hole in between. So there will be parallel circulation. So this is like that only. Suppose this is the heart. In case of transposition of gate arteries, this is left atrium, left ventricle, right atrium, right ventricle. From the left ventricle arises the pulmonary artery, and from the right ventricle arises the aorta. So from the right ventricle aorta, this blood, deoxygenated blood, goes to the systemic circulation and again comes back to right atrium through inferior vena cava and superior vena cava. And from the pulmonary artery, the oxygenated blood goes again, it goes to the lungs and it comes again to the left atrium via the pulmonary veins. So here is a parallel circulation. There is here a question mentioned there is interventricular septum, no defect in between. So it is a parallel circulation undergoing. So if we have a ductus arteriosus patent here, the ductus arteriosus is here, ductus arteriosus connects the pulmonary artery with aorta. If the ductus arteriosus is present here, this side we have oxygenated blood and the body is receiving deoxygenated blood. If this ductus arteriosus is present, there will be mixing of blood. Some amount of oxygenated blood from the left side will go to the right side. So there will be improvement in cyanosis. So till the ductus arteriosus is present, since after the bath, after 10 to 15 hours, there will be functional closure of this ductus arteriosus. That will lead to decrease in flow of oxygenated blood from the left side to right side. So it will lead to closing of PDA, will rapidly worsen the cyanosis in TGA. Whereas in tetralogy of Fallot, opening of PDS improves cyanosis, same thing. So in case of TGA and TOF, we have to keep this ductus arteriosus open before we are doing surgery. If by giving some prostaglandin analogs, if we close them, then there will be worsening of cyanosis. In tetralogy of Fallot, there is already decreased pulmonary blood flow. Decreased pulmonary blood flow. In case of TOF, there is decreased pulmonary blood flow. This is pulmonary artery. This is aorta. Decreased pulmonary blood flow. Now aorta has high pressure than pulmonary artery, so there will be some amount of blood flowing through the ductus arteriosus towards the lung. So if we block that, in case of TOF, opening of this ductus arteriosus will improve the blood flow to lungs. So tetralogy of Fallot improves opening the patent ductus arteriosus. A child with large PDA develops Eisenmenger syndrome. Now has cyanosis only in lower limbs, whereas upper limb remains pink. So how it develops? So Eisenmenger syndrome is sound reversal. Normally the PDA sound is left to right sound. Okay, PDA sound is left to right sound because left we have aorta and right we have pulmonary arteries. Aorta is connected to left ventricle with high pressure and pulmonary artery to right ventricle with low pressure. Normally the sound is like that. But once the pulmonary hypertension develops, there will be sound reversal and there will be right to left sound. So when the sound is right to left, now this blood will move like this. From the right side, it will move to left side, or from the pulmonary arteries, the blood will move to the aorta. Aorta is carrying oxygenated blood. This oxygenated blood is going to right brachiocephalic tongue. Oxygenated blood is going to left communicator. Oxygenated blood is going to left subclavian artery. But now this deoxygenated blood, which was coming from the pulmonary artery, due to sound reversal, it will go down. So this deoxygenated blood goes down. That will lead to cyanosis in lower limb, whereas upper limb is pink. Upper limb is pink is due to this oxygenated blood, and this lower limb is become blue or cyanos due to deoxygenated blood due to sound reversal. So this is a very important concept. Now let's discuss another thing. Why the differential cyanosis is reversed? That means the differential cyanosis is reversed, and in case of TGA with PDA and pulmonary hypertension. Now what we discuss? We discuss a condition in which we have large PDA develops Eisenmenger syndrome, and there will be cyanosis only in lower limbs. No cyanosis will be there in case of upper limbs. Now here is another condition where differential cyanosis is reversed. Upper limbs become cyanotic, lower limbs becomes pink in TGA with PDA. It's a very important condition. Let's discuss it. So TGA means transposition of great arteries. Okay, transposition of great arteries. So this is suppose our heart. So this is where our left atrium, this is right atrium, this is left ventricle, this is right ventricle. In case of TGA, from the left ventricle, instead of aorta, pulmonary artery rises, and from the right ventricle, aorta rises. But their input is normal. Here it is pulmonary vein, here it is SVC, IVC. This is my tricuspid mitral valve. So what happens? Now, what is pattern ductus arteriosus? Ductus arteriosus is the connection between these two. It's connection between aorta and pulmonary artery. Ductus arteriosus is the connection between aorta and pulmonary arteries. I have to make this diagram here so that we can understand it better. Ductus arteriosus is a connection between aorta and pulmonary artery. So this is ductus arteriosus connection between aorta and pulmonary arteries. So what happens here? In case of TGA, there will be oxygenated blood in the left side. So this is oxygenated blood, and deoxygenated blood will be on the right side. The parallel circulation is going on. When there is shunt reversal, differential cyanosis is reversed PD with pulmonary hypertension. When there will be development of pulmonary hypertension, normally what happens? Normally left ventricular pressure is more, so oxygenated blood is moving from pulmonary artery towards the aorta. So from the pulmonary artery, the blood is moving towards aorta, oxygenated blood. Is not visible clearly. So oxygenated blood visible here. From the pulmonary artery, oxygenated blood moving like this. And from the aorta, this is the aorta. Aorta is carrying deoxygenated blood. Deoxygenated blood. I am writing in blue. So deoxygenated blood is coming like this. So when there will be shunt reversal, the pulmonary artery pressure will rise. Due to pulmonary hypertension. There will be shunt reversal. Blood will flow like this from the pulmonary artery towards the ductus arteriosus. So this oxygenated blood will flow like this. So this oxygenated blood is going down. So lower limbs become pink because oxygenated blood is going down. On the other hand, this deoxygenated blood which is present in case of aorta, it is going into right brachiocephalic trunk, left subclavian artery. So these upper limbs will be cyanosed. So the upper limbs become cyanotic and lower limb becomes pink in case of TGA with PDA and pulmonary hypertension. So this is a very important concept. Let's discuss another concept. Two cyanotic babies have oxygen saturation of 70. You give them 100% oxygen, then who will improve more, or what will happen now? In generally, both of them will not improve because this is what hyperoxia test is. Hyperoxia test is that we give 100% oxygen. If it is a pulmonary condition, then there will be improvement in oxygen saturation if it is a pulmonary condition. If there is no improvement in oxygen saturation after giving 100% oxygen, then it is a cardiac cause. It is a congenital heart disease. So while after giving 100% oxygen, no one will show significant rise in PaO2. So none of them will show significant rise in SpO2 or oxygen saturation because they are cardiac causes. In case of respiratory disease, if you give 100% O2, there will be improvement. But in case of cardiac, there will be no improvement. That is the case. Now, even if there is no improvement among these two, among tetralogy of Fallot or TGA, who will improve more or who will improve less? This is the question here. Both of them will not show significant improvement, but who will improve just a little bit? Who will improve? The guy with TF will improve. Why? Because, so this is TGA baby. If you give oxygen to TGA baby, so this is left atrium, left ventricle, right atrium, right ventricle. So we give oxygen to this TGA baby. pulmonary veins, then this is pulmonary arteries, this is aorta, this is IVC, SVC. So this is our lungs now. From pulmonary arteries, blood is going to lung, getting oxygen and coming to pulmonary vein. In case of TGA, there is an interventricular septum. This is occidental blood is flowing on this side, and deoccidental blood is flowing in this side, parallel circulation. We give oxygen towards the lung, give oxygen, 100% oxygen. This oxygen will be carried out the blood and it goes to the left atrium through the pulmonary vein, occidental blood in the pulmonary vein. Again this occidental blood will go into pulmonary artery vein, lung, again will get. So this side only oxygen saturation will improve, oxygen concentration will increase only on this side, but in this side there will be no oxygen. This is the aorta, this is what supplying whole of our body, so there will be no improvement at all in case of baby with TGA. But in case of TOF, tetralogy of Fallot, there will be improvement because there is ventricular septal defect present in between. So there will be some improvement seen in baby A, but there will be no improvement in TGA baby. So this is all about. Let's discuss some other conditions. Alpostadil is a prostaglandin E1 analog used to keep doctor open medically in coarctation of aorta. Okay, the doctor is a fetal connection in between pulmonary arteries and descending aorta. Functional close at 10 to 15 hours after birth. Anatomical close 10 to 21 days after birth. Survival of newborn with heart lesions such as coarctation of aorta, hypoplastic left heart syndrome, and transposition of gate vessels. All these conditions depends upon the patency of doctor. In these conditions, there is severe cyanosis, so there need to mixing of some blood. So in this condition, there need a mixing of blood. So in these conditions, we have to keep the doctor patent. Closure of PD in such condition can lead to hypoperfusion, severe hypoxia, and cyanosis. PGA1 is a potent specific relaxant of ductal smooth muscle. PG1 alprostadil mejoprost can be used to keep doctor open and support systemic blood supply. In patent doctor, it is closed medically by NSAIDs, which inhibit postural sympathies like ibuprofen, indomethacin. Ibuprofen is preferred more than indomethacin because indomethacin is nephrotoxic. Morphine can be used to manage respiratory distress, but rarely in a neonate. So this is all things. You will take a screenshot and read all these things. This is theory. This is also theory. Take screenshot and read it. So this is also theory. Take screenshot and read it. The above findings suggestive of large VST, which is congestive cardiac failure. X-ray suggest pulmonary oligemia, which is not seen. Rest, shock, rest cycle is important. Rest, shock, rest cycle. Failure to thrive. This word is important. Shock, rest, shock cycle. Shock, rest, shock cycle. Failure to thrive. High respiratory rate, suggestive of congestive cardiac failure. Acyanosis, hyperdynamic precordium, palpable P2 is due to pulmonary hypertension development. Pansystolic murmur, mid-diastolic murmur in the mitral area, suggestive of large VST. Ventral septal defect, there is left to right shunting of blood, and this large volume shunted blood pass through the lungs, which is recognized by chest X-ray as pulmonary plethora. And there will be congestion and development of infections also. Increased pulmonary vascularization. Other findings chest X-ray include cardiomegaly with left ventricular apex. CT ratio, cardiothoracic ratio, that will be increased. If the defect is large, flank pleural effusion can be seen. What is NADA's criteria? It is used to diagnose congenital heart disease. One major or two minor criteria is required to diagnose a congenital heart disease. What are those? So major criteria is any systolic murmur of grade 3 or more, any diastolic murmur, systolic murmur of grade 3 or more, any diastolic murmur, cyanosis, and heart failure. Cyanosis which is not improving even after giving 100% oxygen. So that is this cyanosis, the hyperoxia test, congestive cardiac failure. We measure the oxygen saturation pre-ductal in the right arm and the post-ductal in the right leg. So main criteria systolic murmur less than grade 3, and now abnormal S2, abnormal ECG, abnormal X-ray, abnormal BP. Systolic murmur less than grade 3, abnormal X-ray, abnormal ECG, abnormal S2, and abnormal BP. One major, two minor. So the structure foramen oval, Ghost develop fossa ovalis, umbilical vein, ligamentum teres, ductus venosus, ligamentum venosum, umbilical arteries, medial umbilical ligament, ductus arteriosus, ligamentum arteriosum. So this is all about CVS. Now it is complete.